So I'm John Lambourne, I'm one of the Microbiology and Infectious Diseases Consultants at Barts Health NHS Trust. If you imagine getting on the tube, don't be alarmist, but you're probably safer working on a ward wearing PPE than you are kind of on the tube, partly because you're on the tube, you can't control your environment quite so much. There's probably a bit less ventilation in a tube carriage than there is outside, and so it's just thinking about how are you going to acquire COVID if it's on the tube and if it's around. It will be someone who's got on the tube, who has coughed and spluttered, and it's going to come out and it's landed kind of on the seat or on the handrail or this or that, so it will be touch surfaces. It may be in the air, someone has a cough, that sort of thing. So in all honesty, I don't think it would be unreasonable to wear a face mask. It probably doesn't have to be a formal surgical face mask. The reason for the surgical face mask is you're in close contact and you're going to get a droplet that lands on you. So the surgical face masks are water repellent, which means they can withstand water hitting them. Whereas on a tube, you'll be rather unlucky for someone to be that kind of productive and be in such close contact for that period of time. So I would say it's not unreasonable to wear just a normal, face mask sort of thing, but I think I would pay close attention to hands and things, and that's, clearly it's reviewing what you do with your hands on the tube and being cautious, I guess, about picking your nose and scratching your eye and picking your teeth and that sort of thing, and trying to avoid doing those things. And then when exiting the tube, and once you've gone through and you've dinged and all that sort of stuff, then it's about kind of hand wash, and I guess, or hand cleaning. And I guess the other thing to say about washing is that it's not a particularly difficult bug to kill, is my understanding. It doesn't form spores, it doesn't need particular kind of heating or sporicidal wipes or anything like that. Alcohol hand rub, soap and water, claw clean bleach, green Clenel wipes, red Clenel wipes, they're fine. They'll be active against it, sort of thing. So alcohol hand rub is perfectly fine. So have a bit of it in your pocket or in your bag when you exit the tube. Then kind of do that. The other thing about testing that's going to be really important coming up is the idea of serology. So PCR tests currently will detect viral genetic material. Serology is a blood test which asks, has your immune system seen this infection? So we do serology for kind of Hep B, for measles and mumps and all that sort of stuff, to check immunity. And so this is asking, is this person immune now to COVID? There are several challenges to that, in that there are 4 or 5 other strains of coronavirus that circulate most winters anyway, that we're all exposed to and that we will all have antibodies to. We will have all developed some immunity to them. What we don't want to do is we don't want to pick those antibodies up because everyone will have them. We want to pick antibodies that are specific to COVID. And also, the body's immune system will evolve its immune response to COVID. So you'll get antibodies, imagine this is your COVID bug, you'll get antibodies directed to lots of different bits of the bug, so the outer bit, the inner bit, the RNA, the protein, all the different bits to it. What we would really like to measure are antibodies that have a functional impact, meaning that if you're exposed to COVID again, those antibodies bind to the bug and prevent it binding to host tissue and prevent it invading and things. So you can have antibodies that might exist that don't do any of that, and you're re-exposed and the bug kind of gets in quite happily. There's no point measuring those antibodies. We want to measure what are called functional antibodies that neutralize the virus and prevent it entering. And so there's a couple of limitations, or not limitations, there's a couple of bits that serology has to get right for the test to be meaningful. And again, the same thing holds in terms of lots of people will produce serology tests to say, this will tell you if you've got COVID or not. But I think that, again, we need to have some caution and put through the right validation for these tests to go, what's the false negative, what's the false positive? What you don't want to do is to say that we've detected COVID antibodies, great, you're protected, but actually that person isn't. They then perhaps don't observe PPE quite as cautious as they should do, and then they get it. That will be a risk and a poor outcome. If I have antibodies, does that mean that I am protected? Does that mean that I can't get it again? And I think the current understanding is Probably yes, for a couple of reasons. So one, if we look at MERS and we look at SARS, individuals who have had those, they're both very similar, they're quite similar coronaviruses to COVID. Individuals who have had those infections generally demonstrate reasonably high concentrations of antibodies to those infections for a year, 18 months after they've had the infection. So people do generally make antibodies. And as far as I'm aware, there have been no documented cases of reinfection with the MERS or SARS. The caveat to that is that compared to this, they were both tiny outbreaks. And so not many people were exposed. From what I gather, I don't think there are that many cases or reports of individuals having COVID twice. There have been a couple of case reports where people say they had it twice, but I wonder whether that might be more to do with the inaccuracy of swabbing. So you get a patient who was tested positive, swabbed on day 3 negative, tested on day 7 positive. That I don't think is a reinfection. That I think is one infection where that middle test was null and void, I think. So, but the expectation is that if you have the capacity to make antibodies and you can detect them, then you should be protected. Now that doesn't mean we're going to send people to the front line who have had it and have antibodies with no PPE, but it just means that you go into that situation wearing PPE, perhaps a bit more reassured. So viruses are very clever, as are bacteria. They evolve over time and they change how they look to the immune system. That's one of the ways they've evolved. So they change the structure of their outer surface coat. And by doing that, it means the immune system that recognised the virus last year doesn't recognise this year's virus, which is why we've got to have an annual flu jab, because there is no epitope, there is no area on the flu virus bug that is consistent and conserved from year to year that the immune system reliably recognises. We don't know about COVID, about whether it will be different. So say, for example, kind of measles, for example. Measles has a number of epitopes or a number of things on it and in it that are well recognised and that do not change over time, or the virus doesn't change those bits over time. So it means you had a measles vaccine, it means you're protected. You know, that's, by and large, that's the case unless you lose your immunity. But for flu, that isn't the case. We don't quite know about COVID as to whether a bit like once you've had the infection, so what a vaccine is trying to do is trying to replicate having the infection naturally, but without clearly the downsides of having the infection. And so, yeah, I'm not sure we know yet whether or not we'll be able to replicate that. But I guess if you take normal circulating coronaviruses, they are the cause of the common cold, so they do circulate kind of year after year. So there is some idea that the virus does change, which means you can get reinfected. But that's probably with different strains on different years rather than the one strain changing. People have looked at the I guess what you call the genetic clock of the virus in terms of how quickly it evolves or changes or mutates. I think it's thought that COVID or coronaviruses probably change less rapidly than flu, than influenza A or influenza A particularly. It's got a slightly different genetic structure, which means it doesn't reassort quite as, or doesn't alter its structure quite as quickly as flu does. So, yeah, vaccines always the holy grail in terms of can you give it, but I suspect, like most things, like most vaccines, that'll be much more difficult than a blood test. That will need trials. It will need to be proven that it works and things. And I wouldn't. That's kind of year to 18-month territory sort of thing. So it won't help us with this wave, but it may be something that comes in for wave 2 and wave 3. Looking at psychology of mask wearing, I think my understanding is in Southeast Asia, wearing masks is seen as much more culturally acceptable and appropriate, with the message being that I have some symptoms and I don't want to give this to you, whereas I think traditionally in this country and perhaps the West, wearing a mask is being perceived as going, you all have got infection that I don't want to get. So I think we need to shift that to kind of go, look, I'm protecting you in case I'm harbouring this, because that's equally plausible. I mean, you could be an asymptomatic carrier, and the idea of wearing a mask, again, is you're protecting your co-tube people, for want of a better word, but also you're protecting yourself. So I think that would be easier to do in a more widespread fashion in the current kind of climate, I think. So yeah, it's really interesting looking at psychology of mask wearing and how in some cultures it's completely kind of appropriate and accepted. It's to do with particle size and how those particles respond in the air and to gravity. And so droplets are generally large particles, so greater than 10 microns in diameter. And they are believed to generally follow the laws of gravity. So they are expelled by kind of coughing or sneezing or sometimes even by just talking. But those droplets obey gravity, so they fall to the ground, which means they have a limited radius around the individual. And so the main infection risk for them is thought to be contaminated kind of surfaces around the individual. So it's bed rails, it's side tables, it's stuff that the patient is around, and some person-to-person transmission in terms of droplet for close contact. So say if you're less than a metre and a half away, the idea is that droplets can be expelled but then land kind of on you or possibly be inhaled into the mouth. And that's how infection is set up. So either by inhalation into the mouth, contact with the eyes, or the person kind of touching the environment and then rubbing their eye or picking their nose or sucking their finger or that sort of thing that we do all the time. And the idea about the droplets as well is that even through inhalation they're thought to be large enough that they don't tend to penetrate that far down into the airways. They don't go all the way down into the small airways at the periphery of the lung. And so it's thought that they tend to establish infection in the upper airways. So that's droplets, and which is why what we call kind of droplet protection PPE is geared towards protecting that sort of exposure. So it's a surgical mask, so it's to stop the droplets landing on you. It's an apron, again, to stop droplets landing on you, and it's gloves, so in terms of touching things. And it's eye protection when you're, again, in close contact with someone who's kind of coughing or sputtering or has a nebulizer going or something like that. The other group is thought to be the kind of aerosol transmission, and that is thought to be due to smaller particles, so less than 10 microns or sometimes even less than 5 microns. And the issue with those is that because of their size, is that they don't obey the laws of gravity, and so that they can remain in aerosols in the air for a period of time, and they can have a much wider range, and they follow currents and eddies. So there's an aerosol, someone opens the door, that will generate an airflow that the aerosol will allow the aerosol to kind of transmit out and about. And because they don't obey gravity, they can, with breathing, they can entrain under the surface of the mask, which is why for aerosol PPE, it's much wider coverage. So again, it's gloves, but it's a long-sleeved gown. It's what's called an FFP3 mask, and again, it's eye protection or a visor, again, to try and prevent both droplet and aerosol. The reason for the FFP3 mask is that it's tighter fitting and has a much greater kind of filtration capacity than a surgical mask. What determines an aerosol generating procedure? So it's things like kind of intubation, extubation, high flow oxygen, non-invasive ventilation. Where the idea for aerosols is you need quite high flow air going over a surface. But there's debate about, is coughing an aerosol generating procedure, is nebulized therapy an aerosol generating procedure, is doing CPR an aerosol generating procedure, is doing an OGD, so a camera down the gullet sort of test, an aerosol generating procedure. Those are all things that at the moment are thought not to be, but largely because there haven't been the cases described following those procedures. That doesn't mean necessarily that they can't be associated with aerosol. So I think one benefit, if you can think of it in that way, that this pandemic will have is that there'll be an awful lot more focus and research in terms of aerosols, and so our awareness and knowledge and practice of proper personal protective equipment will improve from now kind of going forward. But I guess one of the struggles is that it feels like guidance is changing every week. I think there's another important thing to state is that putting PPE on is an important part, but actually taking PPE off can be a risk as well. And we learnt from Ebola and also from other outbreaks that actually the risky time and the point of you're most likely to inoculate yourself is as you're taking the PPE off. Putting it on is fine, that's easy, you're clean, you're putting PPE on, whereas you're taking it off, you've got a contaminated surface on the outside. The steps required to take it off and take it off properly, so you don't then kind of get a handful of stuff and rub your eye with it, that's where it's important. And I think we pay a lot of attention to the donning, but less attention to the doffing or taking off of stuff. So, I mean, no test in the history of microbiology or virology is ever or will ever be 100% sensitive and specific, meaning it will always identify an infection if it's there, and it will kind of only identify that infection. So there's always going to be a rate of false positive, meaning that you get a positive result but actually the patient doesn't have it, or more importantly in this case false negative, where the test comes back as negative but the patient actually does have it. So some of that comes down to sampling and where you sample. And so we think that throat swabs probably have the lowest sensitivity. Nose swabs have a higher sensitivity. So we think throat swabs probably about maybe 40 to 50% sensitive by themselves. Nose swabs probably about kind of 65, 70% sensitive. The two combined is probably about the same, so 75% is kind of sensitive. But that means there's still 25% of people who, if you really look or look in a different place or you look again, will have COVID detected, but just don't on that sample, which is why we say one swab in the throat and in the nose. Throat swab, you've got to gag, because it's got to be a proper deep throat swab. And the nose, it's not just a tickle in the front of your nose, it's the swab going right to the back of your nose where you feel resistance and you twizzle it around so you feel like you're about to cry. It's not hugely pleasant, but it means you've got the best chance of finding it if it's there. What we're also doing now in terms of patients who are coming through on the Barts site alone, who are having thoracic surgery and cardiac surgery, where we've got access to deep respiratory samples because the patient's intubated, is getting some of those deep respiratory samples, because we think that the sensitivity of a deep respiratory sample is probably more up in the 95, 97% thing. So if we say that someone's had a deep respiratory sample sent and that's negative, actually we're much more confident to say, do you know what, this patient doesn't at this stage have COVID.